certified in pediatrics, pediatric gastroenterology, and she's an author of many, many articles. Until very, very recently, she worked with the Children's Hospital of Pennsylvania. She has a tremendous interest and commitment to families living with hepatitis B. She was instrumental in the 2 pediatric workshops that Joan has mentioned, and she is one of the authors. So thank you very much.
Thank you. I want to say thank you to the Hepatitis B organization. They're an amazing organization, solely dedicated to one disease, which really differentiates them from many other foundations that provide information. When I go someplace to look at what's the latest, I often comb through their website to see what I might have missed, and it's very, very useful. I, for 22 years, was at Children's Hospital of Philadelphia, and one morning I decided to change my job. So I am now at Merck, and this conference was in the making, and so it's one of the last things I will do before I hand over the reins to Jessica Wang, who's picking up the viral hepatitis program at Children's Hospital in Philadelphia. I also want to mention Jessie and Oyinkan, who are in the back, who work with me and have been great for a number of years, and it's Jessie's birthday, and she just delivered her child, and she's still here. So I was worried before coming here that Merck, I get competitive information every morning, and worried that they were going to find out that I was talking on a topic and it's with an unapproved slide deck. It's true, they worry about these things. But I was assured that there's no conflict of interest, it's okay. We don't really do much for hepatitis B, unfortunately, even though I'm in Merck hepatology. Most of my focus right now is on hepatitis C. So I'm going to give some background. It's hard in an audience like this where a good number of people have a large chance that they might know more than I do, since they're probably reading all the time, and then there's other people who are at the beginning of the learning curve. And I'll try to accommodate everybody, and please don't hesitate to interrupt. Well, I went the wrong direction. Let me use this. I don't know why they didn't work. So I'll start out with some background and some information from the Institute of Medicine report that was published in 2010, and that is that 15% to 25% risk of early death with hepatitis B caused by liver cancer or end-stage liver disease among patients with chronic hepatitis B. And I always feel a little bit nervous with parents of giving the scary information, because you do have children that are healthy, but this is why we worry about the future. The WHO Global HPV estimates that there's 2 billion people infected with hepatitis B, 350 million people living with chronic hepatitis B, and 1.25 million in the US. And there's approximately 600,000 deaths annually caused by hepatitis B-related liver disease or cancer. In 2008, there was a campaign that was called AmINumber12.org, and that is because 1 in 12 people worldwide are living with either hepatitis B or hepatitis C. So it's a very common problem, even though I'm sure many of you feel a little bit isolated in the United States, where it's a little bit less common. This is a world map showing the hepatitis B surface antigen prevalence, and the areas in green are areas that are considered high prevalence areas, which is obviously some of Asia, Africa, parts of South America, Greenland, and the northern parts of Canada. There's intermediate surface antigen prevalence in the areas in this sort of lighter greenish yellow, and low areas of prevalence. Let me translate that. Oh, somebody messed with my slides.
It was Merck, right?
Must be. Unfortunately, this is getting recorded. We'll have to put blanks over that Merck stuff. Beep. So, I want to give you a perspective on what that means. So, when you have surface antigen prevalence of 8% or greater, there's 40 to 45% of the global population. 10 to 20% of those people have a positive surface antigen. The lifetime risk of infection in those areas is greater than 60%, so very significant. And early childhood infections are very common. In the areas where there's intermediate prevalence, 2 to 7%, the global population for that is 35 to 43%. The lifetime risk of infection is somewhere between 20 and 60%, and infections occur in all age groups. In low areas of surface antigen prevalence, this is a small portion of the world population, and the lifetime risk is less than 20%. Most infections occur in the adult risk groups. The impact of immigration, though, has had there's been a significant impact of immigration on how this all plays out. And so even though the United States is an area of low surface antigen prevalence, there's obviously pockets of communities where it may be much greater. And if you move from an area where there's high surface antigen prevalence, if you're a carrier and you move to any of these other areas, it's not like you got rid of the disease. Adoptions, for many of those in the room, mother-to-child transmission are common. So you need to know how you get this. Horizontal transmission, which is from two people, from one person to another, as opposed to mother and a child. The answer, the way in which you get this, is high likelihood in blood, in serum, in wound exudate, so the gooey stuff that's around a cut. Moderate contamination with virus in things such as semen, vaginal fluid, and saliva. And don't get hung up on the saliva, because kissing's okay. But it is a sexually transmissible disease. Lower undetectable levels are in urine, feces, or poop, as we know in the GI community, sweat, tears, and breast milk. So breastfeeding is allowed. Vertical transmission is increased when the mother is E antigen positive. There's a 90% chance of the infant being infected, and I'll show you some curves, which I'm sure many of you in the room have seen before. There's a 20% risk if mom is E antigen negative. So even when they're E antigen negative, mostly if they're shedding virus, you still can transmit the virus. You can have vertical transmission if the mother becomes infected, especially during the 3rd trimester. So moving on to what makes children different. Why should we care about children? And I usually think of 3 questions. Does hepatitis B impact the life of children? Do children get cirrhosis or cancer? And do children feel ill? The answer to that is pretty simple. And hepatitis B impacts the life of children, yes, even though it's a future worry. Do children get cirrhosis or cancer? And the answer is very rarely in the pediatric time frame. But that still doesn't mean that we shouldn't be concerned about their future. And do the children feel ill? And the answer is rarely, which is one of the reasons why, prior to giving up clinical practice, was my favorite reasons to deal with families with hepatitis B, is that you're dealing with a healthy child, and it's allowing the family to understand what's important, what's less important, and guide them through the decision-making process. It's a very socially difficult disease. You have problems with daycare, schools, sleepovers, dating, and those are often the types of questions that are asked in the pediatric setting. Do you disclose or not disclose? What do you tell people who don't know? What do you tell your child? Because chances are, if you tell your child, and I do believe in telling children, they are likely to say things in ways that might scare other people off. And so those are the types of things that you might have to deal with. There will be a session later on today about whether or not you need to disclose, and you don't necessarily. Long-term health consequences are one of the things that we really focus on in pediatrics, and you always have the worry that it's a highly contagious disease. So the differences in pediatric hepatitis B are children are less likely to clear hepatitis B if you get this during the pediatric time frame. There's only 5% of newborns that acquire the infection from their mother at birth who will clear. And this is the classic graph that most people know, which the yellow line at the bottom, let's see if I can use a pointer, shows the likelihood of hepatitis B infection being symptomatic, and at birth it's very low. Somewhere after a year of age it increases until you act like an adult, where if you come in contact with the virus you're likely to have symptoms of feeling sick, possibly becoming jaundice, having a fever. Chronic infection is the inverse. If you're infected at birth or exposed to the virus, your immune system is such that you rarely clear the virus spontaneously. As you get older than a year of age, and really over 4 years of age, you act much more like an adult, where a horizontal infection is more likely to become cleared. Hepatitis B mortality, other than flu and pneumococcus, HPV claims more lives than any other vaccine-preventable disease. Hint, hint, I'm going to be talking about vaccines. 1,000 die annually from cancer, 4,000 die annually from cirrhosis. The life cycle of hepatitis B virus is a major contributor to the unique disease aspects. Initially, it lives as a plasmid, which is like this little circular thing within the cytoplasm of the liver cell. And with time, it moves into the DNA of the host. And that is why, at this point in history, we find it an extraordinarily difficult disease to cure. So most of what we're going to educate you about is how you live with this in your body and stay healthy for the rest of your life. So I'll start out with prevention and vaccination. The U.S. strategy, and now this has become a worldwide strategy, is to use vaccines to prevent transmission. We can prevent perinatal transmission. There's routine vaccination of all infants in the U.S., and that has made a huge impact. There's vaccination of children in high-risk groups. There's vaccination of all children up to the age of 18, and that's covered under certain laws, so that you should always be able to get the vaccine. After the age of 18, you'll probably have to pay out of pocket. There was a federal mandate, which I just referred to, which is vaccine for children, the VFC rule from 1993. It's also recommended to vaccinate adults in high-risk groups. So the impact of this sort of strategy and a number of other things that have come along gives rise to this curve, and I'll take you through it. So in the, this is U.S. incidence of HPV by years starting in 1967. And at the point when the vaccine was licensed in the 1980s, hepatitis B in the U.S. was still on the rise. Then there were certain things that were implemented that have had a significant impact. One is screening pregnant women for surface antigen so that you can identify people who are at risk. If you identify people who are at risk during pregnancy, you can implement infant immunization. Originally, it was done with just HBIG and done as an as-needed basis. Now it's universal infant immunization. This is OSHA, which are occupational safety rules were established in order to decrease the incidence of people who may have, people in healthcare settings and other settings where you're going to have a high risk of exposure are educated or vaccinated. And that has had, again, a decrease in the new cases of hepatitis B in the U.S. And finally, adolescent immunization was recommended to catch up on all those people who may have missed being vaccinated when they were young. The hepatitis B vaccine school entry laws, unfortunately, are a state-by-state issue. So those states that are in yellow, there are states where it's mandated that at middle school to high school you have to be vaccinated. The areas that are in white, and I don't believe this has changed. Am I out of date? Not yet. Okay, I was just wondering that the white states are areas that don't believe in screening and implementation. I don't know if that's exactly the right wording, but they don't mandate it. Hepatitis B vaccination recommendations currently, it's routine for all infants. Ages to 11 to 15, there's catch-up. up to the age of 18 for anybody who may have missed it, and it's covered under your insurance or vaccine for children, so it's almost always paid for. Over the age of 18, if you're high risk, it's recommended that you get this, and these are the categories that would be considered high risk. Occupational health workers, hemodialysis patients, people who have multiple sex partners, inmates, men who have sex with men, IV drug users, and institutionalized individuals. Hepatitis B vaccination recommendations. Post-vaccination testing is recommended for not everybody, but if you do it, it's 1 to 2 months after the last shot of establishing this information is critical. And for most of the people in this room, it is. If you're living with somebody who has hepatitis B, everybody in the household or who has significant contact should be vaccinated. The reason why it's recommended that it should be checked 1 to 2 months after the last shot is some people can have an adequate antibody level and it drops, but it doesn't necessarily mean that your immunity has dropped. So it's the best timing to know whether or not you have immunity. Testing is recommended for infants born to surface antigen positive mothers, healthcare workers, HIV patients, dialysis patients, non-responders if you've found yourself in that situation, household members living with infected people.
May I ask something?
Mm-hmm.
If a family is traveling to China to adopt a child, should the entire family be tested prior to the child's arrival?
You mean if
They're adopting a child infected with hepatitis B. Should because they'll now be living with someone with hepatitis B, should they all have their antibodies tested? And when are boosters needed?
Let's see if I have like the next one about boosters.
I'm sorry.
No. So I shuffled all my slides this morning. It's like I'm never sure what's going to be the next slide. So this last line where it says the anti-S level of 10 IUs per ml, that's what's considered protective. In terms of a family, and some things aren't written out there as a clear recommendation, I would recommend, first of all, if you're all going to China where it is a significant risk because of the number of people who have hepatitis B, you should be vaccinated. Every person who traveled over there. If you're in this country, you didn't travel with every single member of your family, I recommend that everybody, grandparents who are going to babysit, if you don't want anybody, they should all be vaccinated. I'm much more likely to involve as many people as possible. It's always better to be vaccinated. It is a preventable disease. And you don't want that sort of fear of interfere with your relationships.
But you would have to follow up anti-HBs titers checked
I would.
for all family, for all.
I would.
household members.
Anybody who's going to be at risk of contracting the disease, so people who have real contact, the answer is yes, they should all get their titers.
And if a sibling has surface antibodies that are below the recommended level, what would you recommend?
So let's see if it's there. I can tell you who messed with my slides, but because I hate it when it doesn't like all show up all at once. So back to your question about whether or not, if you established previously that they were 10 IUs per ml or greater, and you showed that at one point in time, if they decline after that, you don't need to give them a booster, unless Tom London tells me otherwise. But that's certainly, he had more experience on some of these situations. They said he knew everything. So it's thought that you can have an amnestic response. You can even have undetectable titers. And then when you're exposed, you mount a very good response. So for people who you're not sure exactly whether or not they're protected, you sometimes give a booster and check 2 months later. And when you do that, you will know whether or not that sub-therapeutic titer is adequate. And so it doesn't mean automatically that you have to go through a whole vaccine series again, if you can prove that you can get over 10 with your booster. Does that cover all of it? Okay. Generally, when people are vaccinated, we do not do any sort of testing beforehand. It's just that you give the vaccine. That doesn't mean that that's how things should go when you're entering the screening population. But when people say, I'm fine, I was vaccinated, if they weren't screened, there's a chance that hepatitis B could have been missed. Hepatitis B core antibodies an indicator of a current or previous HPV infection, so sometimes that's used in the screening algorithm as well. So if you combine surface antibody, surface antigen for screening, you catch most people. And people who are really at high risk, those people who are about to go on chemotherapy, immunosuppressants, things like that, core is another component that should be added to that series of tests. Infants in treatment. So when you're worried about mother-to-child transmission, what you need to do is hepatitis B immunoglobulin as soon as possible and within 12 hours of birth. You're supposed to get the vaccine for the child at birth, second dose at 1 to 2 months of age, third dose 6 to 18 months. And it's this combination of HBIG within the first 12 hours and the first dose at birth that has resulted in a highly effective regimen. HBIG alone is only 75% effective. When you add the vaccine to it, it's 95% effective, not 100%. We'll get to that in a second. This standard approach has had a huge impact on the children in the United States. So this is incidence of HPV infection among children of all races in the U.S. And let's see if I can get this. So for Asia Pacific Islanders, that's in the purple line, that back in the 1990s, the incidence among persons less than 19 years of age was 100,000. So this is cases per 100,000. So 6 cases per 100,000. Whereas the African American community was here, which is 4 per 100,000, American Indian, Hispanic, Caucasian. But now, close to current history, all have declined significantly. So what are the gaps in the care of the infant vaccine program? Why is it only 95% as opposed to 100%? The 95% doesn't really refer to this first line, but this is a gap, is that not all mothers are screened, and sometimes there's transmission mother to child when the mother wasn't screened. Doses of HPV and vaccine were not prompt enough. That's one of the reasons why it's only 95%. It may be transmitted in utero, that there wasn't a chance that you could have ever prevented the disease from happening because of this transmission. It's really the delivery time frame. And high viremia at the time of birth may also be a factor, that even though we give hepatitis B immunoglobulin, if you have very, very high viral titers, that immunoglobulin may not have been an adequate dose. And people are exploring how that might be approached in a different way. The other thing is that adds to gaps in mother-to-child transmission is that there's guidelines for infants are standardized, but the guidelines for mothers who are infected are not standardized in terms of how to handle that. So mothers are checked for surface antigen, but not everybody is placed on medication or such, which can be a highly effective way to decrease the viral count at the time of delivery. And if you do those two things, maybe you would shift the curve just even a little bit more. Post-exposure prophylaxis. For adults, it's mostly needle sticks and sexual contact. You give HBIG immediately and no longer than 14 days. Just in case somebody has a visiting relative and you don't know what to do with their exposure, call somebody. These are put in more graphic form what to do with HBIG and vaccine. If you're unvaccinated, you give 1 dose of HBIG and you initiate the vaccine series. Vaccinated and a known responder, you're good. Vaccinated and known non-responder, not so good. You give HBIG 2 doses and consider revaccination. And vaccinated with unknown response status, which is actually the majority of kids in the U.S. Stop in 1 second. And there you test for hepatitis B surface antibody, and if inadequate, you give HPV in the vaccine series.
The vaccine series, how many injections is that? Or over what time period?
So there's standards, and they actually do have more than one standard hepatitis B vaccine at this point. The one that I referred to here would be 3, and they're at specific intervals. But those are the sorts of things that family practitioners and pediatricians would know cold. You know, those aren't like, that's not a gap in knowledge. Knowing when you need the HBIG could be a gap in knowledge for a pediatrician. Like they might delay, call the CDC, not get their answer promptly, but you need that HBIG right away and to start the vaccine series.
So worst case scenario in a daycare or school or athletic event, your child with hepatitis B bleeds on someone, maybe who has the worst case scenario, there you would go for number 4, the person, if the situation calls for disclosing, which I would argue is not.
I talked about all the things I liked about taking care of hepatitis B, and then there's the category where it's like, oh.
But there are clear guidelines, if indeed there was exposure, that the child would be tested, and there are these options.
There really are. And you have to wrestle with your social responsibility versus disclosure when you know that this is a fixable situation. So for those people who can take the road of, I'm willing to disclose and my job is to educate you so that you're not in fear, because we have effective vaccines and we have effective methods of precaution. So
those direct blood spills are very, very rare. If nothing, it's more abiding where the skin is never broken, and therefore disclosure is probably not needed.
Right, and I often educate families that the thing to do is you go to the nurse's office. Not that the nurse even needs to know, but they are educated in universal precautions. They're not going to touch blood without gloves. And that you try to teach children to take care of a lot of things themselves, rather than having all your friends run to you. You just like go, oh, I can handle this. And they know how to clean their cut, cover their cut, dispose of things safely, and go to the right source. So that usually covers most things that would come up.
But in this group, I mean, really, most of the children are under 20. So, I mean, universal infant vaccination was started in 1991. So, for most of you with kids who are under 15,
that is
really,
true.
You're not going to face the same kind of issues that parents did 20 years ago when most of the children that your children are playing with have been vaccinated. So you're starting out ahead, and so there should be less anxiety and fear about whether you choose to disclose or not disclose. There should be a lot less anxiety.
That is absolutely true. This slide is obviously geared more towards the pediatricians that when I talk, which is screening. The question is not were you vaccinated. When you're taking medical history or trying to figure out what has happened, you don't say, oh, did you get your vaccine series? It's really were you screened and did you have surface antigen? So these are the people who, in the U.S., it's currently recommended to have surface antigen screening, as well as you could do surface antibody titers to get the full picture. But it's on that world map that I showed at the beginning. It's all the countries other than the ones with the lowest seroprevalence. So it's no longer reserved that you screen just people from the high areas where it's an endemic issue, but also for these intermediate regions, everybody should get screened. So it covers all of Asia, all of Africa, South and Mid-Pacific Islands, Europe, Greenland, Russia, Middle East. There's very few places where screening is not appropriate. So it's more the negative. And most people should get screened. Children born in the U.S. to immigrant parents from endemic areas should get screened, and that's often a gap in terms of general medical care, especially for intact families as opposed to adoptees, where you're considered like, oh, you know, good family, no hepatitis B, and it doesn't work that way. Infants born to a surface antigen mother, even if they have all the appropriate steps, they should get screened because you want to know that it was effective. And children living with a surface antigen positive individual, those people should get screened and antibody checked. When do we know someone has chronic hepatitis B? So now moving on to the more clinical aspects. We define chronic hepatitis B in it. It's a very specific definition for doctors, even though chronic just means you have it for long periods of time. But we use that you have hepatitis B virus PCR, so virus in your blood, at 2 time points, or surface antigen at 2 time points, at least 6 months apart. And really, it should be done with surface antigen. You don't always have the virus in your blood. So understanding and interpreting lab tests and the health consequences, you might actually do better by stopping me here and interrupting, because I wrote out a long list, and they're what we always get. There's different reasons to get each of these tests. We do liver enzymes, and that's your ALT and AST, and it tells you whether or not your liver is irritated by the virus. It releases little portions of these enzymes sitting in the surface membrane of the liver cell into your bloodstream. We do a complete blood count because we're looking for platelet count, white count, things that might give a hint that you're running into liver damage and that these numbers might change. PT is your liver's ability to clot blood, and we look at that. That's a way to really know whether or not your liver is functioning. For all you guys, I'm sure everybody's fine. These are, even though we do them every year, it's very, very rare that there's an issue with these numbers during pediatric time frame, but that doesn't mean that we don't check them. Alphafetoprotein is a marker of both liver regrowth. It's this fetal protein that's made when your cells are turning over. So sometimes we use it as a liver cancer screen, but it isn't diagnostic because there's other things that can make it go up. But that doesn't stop us from doing this. We still get alpha-fetoproteins to see whether or not there's any sort of signal that makes us take other steps. And in terms of the hepatitis B virus, there's surface antigen, E antigen, core, DNA level, genotype, and the antibodies that go along with surface antigen and E antigen. And I know that Karen's going to speak more than I am on each of these tests. And then there's genotype, which I'll talk a little bit about in a couple of slides. And genotype is something that, as we're starting to understand it, it refers to slight differences from one hepatitis B virus compared to another, and it reflects often country of origin and has some health consequences as well as treatment response issues. I was warned that I would be asked this question, which is, what is a normal ALT level? And this is adult data. So this adult data changed our standards, and there is no comparable pediatric data. So until that day happens, we extrapolate in our mind to see where our kids fit in. So the adult data is that there were 9,221 first-time potential blood donors, 74% suitable donors after they exclude all these different issues, which are anemia, serologic reactivity on various screening assays. So they're looking for any sort of hepatitis that could make your ALT go up. Seizure medication, seizure history, sexual disease, and did we have things like BMI, cholesterol, triglycerides, absence of other medicines. So when they get down to the healthiest group, they then looked at the ALT upper limits. And for males, they found out that the ALT is 30, and for females, it's 19. And those standards we talk about, but when you look at your lab slip, it will say your ALT upper limit of normal is 45. And on pediatric times, it's sometimes 60, depending on what standard they're using. For children, we don't know where on that curve the right number is. as your child approaches adolescence and beyond, we start looking at these numbers like they probably do apply.
What's your number? What do you mean, what's your?
You want to know my
I mean,
lab test?
what's your feel when you look at the kids? I know that my daughter's doctor, she has a number where she kind of,
Sits.
yeah.
So it really does depend on age. ALT changes with age. If you have an 8-year-old, are you talking about, because we'll go on to my next slide, which is like, when do you treat? Because I don't give a concrete number there, but, you know, your response to medications depends on your ALT elevation. So you're also weighing that, not just whether or not you're going to start. There's a lot of things here, which that's the next talk. So I am sure that I would probably start somebody whose ALT is over 100, maybe 90, maybe 80, 70, probably. And then I get to 60, 50, 40, maybe. So that's like, I know those numbers aren't normal, but I'm not always sure I'm going to start treatment in that 40, 50, 60. So does that cover, like, you know, and it's really, that's an art, not a science.
Yeah,
So,
that's why I asked, I mean, clearly
yeah.
it's not a science because we don't have a number.
We don't have enough, but, you know, I look at most 25s, so in the adult world, they've become very aggressive about calling numbers that are abnormal. So if you're a female and your number is 23, there are plenty of people out there who might start you on medication. And it's a different situation because some of those medications will decrease your viral DNA and provide a health benefit, which we're less sure of in children. The health benefit for children isn't necessarily the same. And I'll tell you why. So I'm sure you'll see something like this at least twice today, if not more. And the most important thing in pediatrics is to decide where you fit in on this scheme, whether or not you're immune tolerant, which is where almost all kids start, immune active, if you're an inactive carrier or you're a reactivation. So let's start it with immune tolerant, because this is really what most children are. They contract the virus when they're an infant, their immune system isn't fighting this, and they live happily. Their liver is pretty happy with that virus. And so they have very high DNA levels, and even though the standard is your DNA is greater than 20,000 IUs per ml, it could be 1 billion. And that doesn't mean they're sicker. That's where you start out with if you're immune tolerant. It's just part of the process. Your ALT is normal. And that ALT being normal is your strong hint that you're in the immune tolerant phase. And nobody has yet shown that a 3-year-old with sky-high DNA levels and an ALT that's 20 should work to get that DNA down. And you have to balance that. And I'm not the treatment talk, so, but so that is the thing that you wrestle with, is that you have to decide what phase you're in that the gold standard in pediatrics is that you want to develop E antibody and have that E antibody present so that you don't have to be on medications for the rest of your life. That's different than adults until we know better, okay? So the two fields are very divergent on that opinion. Immune active. Immune active is when the DNA starts to decline, your body recognizes that this is something to get rid of, and your ALT shows that your body's fighting the virus. And I always try to describe it as like, who's going to win that fight? Is it going to be the patient, who will then develop an E antibody and the DNA will just continue to go down? Or is it going to just stay like that and smolder and hurt your liver? So that's what you're trying to wrestle with when you decide about treatment. Inactive carriers are people who won the battle and they don't have detectable, or they have just a smidge of virus in their blood. Their ALT is back to being normal, and the E antigen is undetectable, and they have a good E antibody, and that's what sort of holds them in remission. There's no liver inflammation if you do a liver biopsy, and if they had fibrosis, it could get better, and in pediatrics, usually you have no fibrosis. Reactivation is, for some reason, a certain number of people, it will come back up even though you have like gone through that phase and you no longer have detectable DNA. It can come back up even without being put on an immune suppression or going through chemotherapy. And that's one of the reasons why children and adults need lifelong monitoring. You always need to know what phase you're in.
Can I ask you, in all your years of treatment experience, what's your experience for when young children leave the immune tolerant stage and enter the immune active? I mean, I've heard of 20 or 30-year-olds, or is there any magic number, or is that your next
We'll
slide?
talk about genotype. So there isn't a magic number, but we do think that genotype may have a significant impact on that. And it's one of the reasons why, up until a few months ago, I used to check genotype. I'm no longer that person, but I'm sure Jessica Webb will start doing genotype. So the genotype is a sequence difference between these viruses that often reflects its country of origin. So that genotype A is in Northwest Europe, North Africa, Central Africa. There's genotypes B, C, D, E, F, and G. And it's not necessary to know where it came from, but it is important to understand what its impact might be. And when you're trying to decide whether or not you should just wait and let nature take its course, or you might institute therapy, knowing the genotype sometimes can help you. It also helps with understanding your response to medications, but that's not here. And so here you can see the red line is genotype C, and the blue line is genotype B. And I don't have it here, but genotype A I often talk about as being even shifted a little bit further, so that if you follow those patients, people with genotype A are more likely to seroconvert before age 20 or so. Mean age is in the teens. Genotype C, mean age of seroconversion, and I don't have it here and I can't draw it, but it's like 30s to 40-ish. And the difference in the two countries, I'm really simplistic when I teach this. It was like A is for Africa and C is for China. And in Africa, it is more likely to acquire the virus horizontally, maybe at a young age, but horizontally because the mother has seroconverted before delivery. So it's not just that you catch it, but the whole process is different because you're catching it at a slightly older age. You're also more likely to seroconvert at a younger age. Okay? So I don't know, there's like a number of different factors here. In genotype C, where you don't seroconvert into you're well into your childbearing years or beyond, you're very likely to pass it mother to child. And there the children, or they get it vertically, and in Africa more likely horizontally. So.
And genotype B?
We'll go back.
From your
Southeast.
chart, no, your next chart, genotype B means much earlier.
It's earlier.
Conversion.
Without treatment?
Without treatment. So, and this is, you know, sort of early information. It's not as robust an analysis as we would like at this time. So a lot of the data comes from very large country studies where you have 3,000, 5,000 patients. But there's so many different factors that it hasn't been completely teased out as to what's genotype, what's the age at which you acquire the virus, but they're population studies still.
And genotype is determined from a blood test?
Yes, thank you.
Dr. Haber, you didn't mention what happens in an E antigen seroconversion, what, you know, with the ALT rise and...
Not enough.
Okay.
So seroconversion would be when you transition from immune active to this inactive surface antigen. And I described it more in words in showing the curve where you can see what happens to your ALT, that when you're in this immune active phase, your ALT is high and you're fighting the virus. And when you seroconvert, Seroconvert, for most people who use that term, is really going from E antigen positive to E antibody positive. And it isn't, when we use the term very often, meaning surface antigen positive to surface antibody positive. So that E antibody is, used to be told, or we would tell people that E antibody gives you an idea of how infectious you are. Well, it's also because you have more DNA in your blood when you have E antigen positive state. And when you have that E antibody, if it's effective, you're in remission. So I don't know if that was clear, but I did, we can go to the 80 slides that I have after this talk, and I can show you that other slide. So monitoring and counseling. How do you follow up patients with hepatitis B? I usually recommend office visits 1 to 2 times yearly. I do an annual Alphafetoprotein when I was practicing medicine. It is still a strange thing in my heart. Abdominal ultrasound at baseline and at more frequent intervals depending on the age of the child and the alpha-fetoprotein. So I think many people, and it depends on how far you've traveled to be here, we were often taught to do an annual ultrasound, and plenty of people do that, and there's nothing wrong with it. I tended, after the first one, to do it less frequently unless there was some indication on a blood test that other things were going on. So you don't have to have a yearly ultrasound.
Dr. Haber, when a child first comes home, would you maybe do that the first couple of visits, a few more visits that first year or even that first 6 months, just to get an idea of the snapshot of the status there?
Everything is understanding your baseline and knowing where you change from the baseline. So nobody would ever say you shouldn't have any ultrasound. So you do need it. And you might do it annually until more happens, or you might decide you'll do it every other year. We, as a group, and that's one of the papers that are in that packet, sort of had a meeting of the minds to decide how frequently it should be done. So
I was thinking more just the lab work.
The lab work
initially would do more just to get a feel for.
So if you have it depends on the ALT in my mind. And there's a few different scenarios. So depending on the age, I want to be able to offer treatment at the first available time point. So I do ALT certainly at least twice a year, because if you wait a year and they were really had a significantly elevated ALT 6 months earlier, and I often would wait 6 months after your ALT goes up to decide, is this sort of a virus, like you had the cold or something else, is this real, and see whether or not you seroconvert without some sort of intervention. So if you're only doing it once a year, you can lose time. And I do think that better to know than to not know.
So would you do it quarterly maybe that first year they came home, just to?
If their ALT was rock solid normal, probably not. Because also it's unlikely, if you know the genotype and you know the age, not too many 2-year-olds to 3-year-olds, well, 3 to 4-year-olds really, have significantly elevated ALT. So that's why it depends on the baseline.
What is the cutoff for AFP?
Alpha-fetoprotein?
Yeah.
Let's see if it's on the next slide. That's DNA. So I do a full hepatitis B every year. So the cutoff for alpha-fetoprotein, it's on the algorithm, which I think is in another slide. And thanks to Brian McMahon, who is working with us, who has a tremendous experience. And he also has more work with genotype F than the rest of us. So the guidelines are actually very stringent. And so it says that if you go alpha-fetoprotein over 10, that you start doing other analyses, like an ultrasound, to see whether or not it's significant or not significant. Most people are walking around with alpha-fetoproteins who are kids, quite low, like 3, 2, 1. I mean, they're very low. So 10 is probably higher, and you want to know. And with genotype F, it's more likely that he had a number of teens who had cancers. Most of the time in hepatology, when we start seeing cancer, it's 100 and higher. So I don't freak out over a 10, but it's not normal. So you have to figure out why it's not normal. An ultrasound will help. So you get a higher alpha-fetoprotein, you get an ultrasound. And that's how we do it. Okay? Some people would ask, like, so non-invasive monitoring. I put in some of this, which there's really not much. Saying some people would want to know about non-invasive tests. And there's a number of blood tests that can be ordered. FibroTest, FibroSure. We don't use it very often in hepatitis B, certainly in the pediatric setting. We use the ultrasound as the better test. Because we're not looking just, the reason you do an ultrasound isn't just for the staging of the liver, it's also for cancer. You're looking for masses. And so an ultrasound is non-invasive and much broader information. So, recommend that.
And an MRI would not be useful, recommended?
It's, MRIs are great. They're like the gold standard, but it's not necessarily cost efficient, and you get very good information with an ultrasound. You know, it's not like things hide in an ultrasound. MRI is like getting an Apple computer. You know, it's like resolution beyond your wildest dreams. But you don't need that. So, the other is elastography. So there are these things that like punch your liver and see whether or not there's fibrosis. These are like trends in the, it's still not the primary question. We're looking for structural abnormalities. So the ultrasound is really a very good test. MRI would be great, but ultrasound is quick, it's easy, it's cheap, and it's accurate for this.
So could I just ask about the FibroScan, because it comes up every once in a while. You know, it's more acceptable in Europe and through different parts of the Middle East and whatnot. Is it less reliable in kids than it is in adults, or, I mean, do you have a comment, or you just don't really know because it's...
So, in hepatitis C, even in kids, it's reliable. Not great papers in terms of really correlating the degree of fibrosis, but it works, as opposed to some of the other diseases that I've studied, which biliary atresia is like one of the other things I'm very experienced, have a lot of experience with. There, if you send any of these tests, it comes back 0, and they could be waiting for a transplant. So the process of your fibrosis impacts that test. So if it hasn't been standardized for that specific disease, it's useless. And most of the data is hepatitis C. Role of the liver biopsy. Okay. It's a stolen slide and doesn't completely reflect my opinion. So, the purpose of the biopsy, I'll read it first and then give you my take on it, is to establish baseline severity of the disease, which is a reasonable thing to do. Exclude other causes of elevated liver enzymes. Its greatest utility, and I believe this 100%, is for people who do not meet clearly defined recommendations or interpretation of the labs. You can't figure out, is that ALT because they're heavy, and that this is really inflammation from being heavy, or is this the hepatitis B that's making your ALT go up? And the biopsy would help you. Liver biopsy decisions should consider age, and that I strongly believe in because it sort of takes away the first one. I wasn't a big fan of doing liver biopsy as a standard in pediatrics with a normal ALT with no other signs that there's some other process going on, so that you don't always, and I'm waiting to be contradicted in the next, I was an outlier in the pediatric liver world where I don't always see an indication for a liver biopsy unless you're really trying to answer a very specific question. If you're doing it just to establish a baseline, I sort of go, if you're not going to act on the information that you get, are you sure you need it? And so I don't want to contradict anybody's liver specialist, but that's my own bias. Most people do get at least one liver biopsy at some point. So this is included in your packet, and it was a group of us that included Dr. Murray, Dr. London, Dr. McMahon, and a larger group of pediatric liver specialists. And after sitting around a round table for a while, we came up with the following. It was very pleasant. We came up with these recommendations, and so they are not certified by any national organization, but we felt like we brought into the room all the major stakeholders, as you would say, of people who really knew a lot and could make rational decisions. So if a child is newly diagnosed with hepatitis B, we would collect the following baseline information, which was covered in the talk, including family history. As best many of the children are adopted, and if they're not adopted, if you can know anything about the cancer history in the family, especially hepatitis B related liver cancers like hepatocellular carcinoma, it is very useful information in terms of raising your level of suspicion about things that may come along in the future. And then there are 3 different ways in which you just use this to decide when you need to go to a specialist. So in parts of the country, you're dealing most of the time with your family practitioner or pediatrician, but when do you actually really need to be at a liver specialist? So in metropolitan areas like this, I would see most of my patients once or twice yearly. Might do some of the blood work long distance, but in some places it's not quite as easy to do that. So certainly if you have an ALT that's elevated, or an alpha-fetoprotein greater than 10, or if you're E antigen negative, which we didn't go into that much in this series of talks, greater than 2,000, and or a family history that's positive, after that screening, you should go to a specialist for at least a consultation. In these other, and the column all the way to the left, if you're E antigen positive, ALT is normal, your DNA is elevated, and we're thinking that you're more immune tolerant, you would have periodic follow-up until one of those other triggers come along, because that's really when you need action. Sometimes I felt like I was stealing money by saying, oh, I see you this year, you got your labs in advance, everything looks great, there's nothing that we're going to do this year. This specialist, though, provides you with knowledge about maybe clinical trials that are coming along so that you can be sort of the first in the know. It's more of an educational visit at a lot of those times. If your ALT becomes elevated in this middle column, again, those are times when you need to seek specialty care. Do we have time?
We've got 5 minutes.
Oh my God. Okay. So, SLC Guidance, recommending counseling. These are things that most people in this room should know. You have sexual contact vaccinated. Hopefully most of your 8-year-olds are not in that boat. But for adults, it is absolutely recommended that people go on to college and beyond, that your child and young adults should be educated about these things. Barrier protection is good. Do not share toothbrushes or razors. Cover open cuts and scratches. Clean blood spills with detergent or bleach. And that's something that every house should have, gloves and bleach. You're not supposed to donate your blood, organs, or sperm, and it would be thrown out even if you did. So children and adults who are surface antigen positive are expected to be able to participate in all sports, including contact sports, should not be excluded from daycare or school, should not be isolated from other children. They can share utensils, although I try not to share too much, and technically you're allowed to kiss. People ask. Shouldn't drink. They shouldn't drink anyway, because I assume everybody's underage. And if you're positive only for core and from a low endemic area, you should be given the vaccine series.
You touched on a little bit about the donating blood. As a family member, is that going to impact your ability to donate blood?
No.
Oh,
We
yeah.
was. What?
Yeah, you have a family?
I can't.
I can't donate that, because I live with somebody that has hepatitis B. I even called the Red Cross, they said, yeah, but no.
They're not interested.
That's hepatitis test, but no thanks. Yeah, hepatitis.
Interesting.
They don't take the blood.
Just
I was
precaution.
unaware, that's very interesting, but I guess maybe it was too much of an expense for them to throw out people who said, oh, I'm fine, because you are fine.
Right, but you know, really, why take the risk? I know for a problem.
Wow.
But don't they test for that anyway? Wouldn't that
I was gonna
be part
say,
of their
then-
screening?
Right, well, that's what I'm
So
saying, is
do
that
they-
maybe they
do they
just
test
don't
it?
want to go through the whole process of, because there's too much of a likelihood that you might have had an infection at some point. They just don't want to even go down that road because it's going to cost them time and money to figure it out.
Don't they test everyone's blood, whether or not you
Yes.
check on? So what would it shouldn't really matter. But they
They
don't.
probably, in the past, had more,
Well,
I
they
don't
used to
know.
have a thing, like if you knew you were infected, but you felt the stress at work to donate blood with everyone, you could
Right,
check at the
because they
bottom,
check
throw
off
my blood away, I
yeah.
know you can't use it.
Yeah.
So the blood banks are very conservative, and if you're ever in a position of needing to be a recipient of blood, you want them to be conservative. So their threshold of when to accept a unit of blood from an individual is relatively low. My guess as to why they do this, although I don't know any literature or data to support it, it's probably out there, but I just don't know it, is that there are a lot of household members who are not as informed as you all and actually are infected but don't know they are.
right.
And therefore, probably the hit rate when they test the units from that population is relatively high. And again, they're conservative, so they're just going to not use that population.
Very well stated. It's something I was trying to convey, but didn't do it quite as well. So I only have 3 more slides, and they're very much transition slides that move on to talking about treatment. And these are the reasons why we do think about treatment. The first slide shows adverse liver outcomes in chronic hepatitis B, and this is looking at ALT elevation and risk of complications. That when you're at ALT 0.5 times upper limit of normal, which is like really not at the upper limit of normal, it's below the upper limit of normal, you're at the black line on the bottom, and you're the lowest risk. And there's a number of explanations for deeper meaning, but your liver risk and cancer risk, so risk of cirrhosis and cancer goes up with ALT elevation. It doesn't go up linearly, like the higher the elevation, the more likely you are to have these problems. It would be that way if your ALT stayed high forever, but sometimes those highest ones are the ones that are going to seroconvert. And that's why ALT is not 100% correlated, but having ALT elevation is not a good thing for you. This is looking at DNA levels, and we can talk about this perhaps later, but this is from adult data, and it's gives rise to at least many questions in the office about people being very, very nervous about how high their DNA is in their child. And among adults who are followed forward in time, and the mean follow-up in this study was 11.4 years, the higher your DNA level in these adults was the higher risk of cancer. So when your DNA was greater than 1 million, you had the highest risk of cancer. And we have all participants in blue and people who are E antigen negative in the other bar.
I had read something about men being at higher risk for men with Hep B, high risk for liver cancer. Do you screen the boys any more
Differently?
than you do the girls, or
No. Things can change in adulthood in terms of maybe frequency. Everything ties to the lab values you're getting and knowing whether or not somebody's at risk. So they don't get different care. It's just heightened sensitivity to what you're seeing, perhaps. But We worry in the adult population about the DNA, and it has changed the field of hepatitis B so that in adults, even if you're not aiming for seroconversion, you may be kept on a medication to keep that DNA down. In this, it's side-by-side comparison of cirrhosis risk and cancer risk. And again, it was correlates with your DNA level. So in adults, and you all have children now, and some have slightly young adults, it becomes more and more imperative with time to get that DNA under control and ALT elevations under control. And that's why we think about cancer sometimes. So we'll skip questions until the question and answer period. And I'll move on to my esteemed colleague,